Welcome to the Prep Your Patient to Prevent HIV training. This training was developed by Ashley Wynn, BSN RN, and DNP student at George Mason University. Objectives of this training are 1. Describe the progression of the HIV epidemic in the U.S. and strategies to reduce new infections. 2. Discuss the clinical principles of pre-exposure prophylaxis medication and adherence. 3. Explain methods to identify HIV risk. 4. Describe the HIV care continuum to engage patients. And 5. Identify resources to mitigate barriers to PrEP. Introduction. The CDC estimates that 1.2 million people in the United States are living with HIV, and 14% of those people do not know they are HIV positive. In 2018, there were over 37,000 new HIV infections, and the majority of these new infections occurred in the South. HIV continues to disproportionately affect racial and ethnic minorities and gay and bisexual men. Blacks and African Americans accounted for 42% of new HIV infections, and Hispanics and Latinos for 28%, compared to whites who accounted for 25% of new infections in 2018. Disparities between geographic areas and racial and ethnic groups indicate that effective HIV prevention strategies are not reaching high-risk populations. Ending the HIV epidemic. EHE is a public health initiative with the goal of ending the HIV epidemic in the United States by 2030. The plan integrates several public health programs, resources, and infrastructure to improve HIV prevention, diagnosis, treatment, and outbreak response. Collaboration between federal agencies, state governments, and local communities to promote expansion of PrEP is essential to HIV prevention and to meeting EHE's goal of at least 50% PrEP coverage by 2030. Target population. Blacks, African Americans, and Hispanics and Latinos are at highest risk of HIV but have low rates of PrEP use. In 2018, 11.2% of PrEP users were Black or African American and 13.1% were Hispanic and Latino, compared to 68.7% of PrEP users were white. Recent data show that PrEP use has increased since 2012, with a 39% increase from 2017 to 2018, but disparities persist. Public health programs have attempted to address disparities, but further work is needed to scale up PrEP utilization, particularly among high-risk populations. Personal perception of HIV risk, societal stigma, access to healthcare services, and costs are some of the barriers to PrEP care. This map was developed by AIDSview.org, an online mapping tool that allows users to visualize the impact of HIV-related data on communities at the national, state, and local levels. As you can see from this map, PrEP use is not evenly distributed throughout the United States. In 2017, the majority of PrEP users were concentrated in the Northeast, with 61.9 users per 100,000 people, compared to 29.4 users per 100,000 people in the South. To learn more about the effects of the HIV epidemic on your community, you can visit AIDSview.org. PrEP basics. PrEP, short for pre-exposure prophylaxis, is an antiretroviral medication used by persons at risk of HIV infection through sexual contact or injection drug use. FDA has approved 2 PrEP medications. Both contain 2 drugs combined into a single pill. Emtricitabine 200 mg with tenofovir disoproxil 300 mg, brand name Truvada, or emtricitabine 200 mg with tenofovir alafenamide 5 mg, brand name Descovy. Truvada is approved to prevent HIV acquisition among all persons at risk through sexual contact or injection drug use. Descovy is approved to prevent HIV acquisition among all persons at risk through sexual contact, except those at risk through vaginal receptive sex. PrEP pharmacology and efficacy. PrEP inhibits reverse transcriptase, blocking the ability of the HIV virus to replicate within the body. The FDA recommends PrEP be taken once daily, but research shows that even dosing 4 times per week can reduce the risk of HIV acquisition by 99%. For those at risk of HIV acquisition via IV drug use, the risk is reduced by up to 84%. Patients will get maximum protection from HIV acquisition via receptive anal sex after 7 days of use, and maximum protection via receptive vaginal sex or injection drugs after 21 days of use. Identifying eligible patients. Routinely assessing each patient's sexual history should be incorporated into everyday clinical practice. Sexual history is the first step in identifying which patients are having sexual intercourse with partners of the same sex, opposite sex, or both, and what sexual practices put them at risk for HIV infection. For patients who admit to using or a history of using illicit drugs, assess injection practices and refer to treatment as needed. The CDC has developed risk behavior questions to assess a particular group's HIV acquisition risk. Tips to obtaining a sexual history. Normalize talking about sexual health. Let your patients know that you ask every patient their sexual history. Establish rapport with your patients before asking any sensitive questions. Be inclusive and neutral by using their preferred pronouns and terms such as partner. Be aware of your body language and reactions and try to remain non-judgmental. For a thorough sexual history, the CDC recommends asking about the 5 Ps: partners, practices, past history of STIs, protection, and pregnancy prevention or reproductive life plan. Risk assessments. These are the risk assessment questions developed for particular groups. If you are interviewing a man who has sex with men, you would ask the following questions. In the past 6 months, have you had sex with men, women, or both? If men or both sexes, how many men have you had sex with? How many times did you have receptive anal sex? You were the bottom with the man who was not wearing a condom. How many of your male sex partners were HIV positive? If any positive, with these HIV positive male partners, how many times did you have insertive anal sex? You were the top without you wearing a condom. And finally, have you used methamphetamines such as crystal or speed? If your patient is a heterosexual male or female, you would ask the following questions. In the past 6 months, have you had sex with men, women, or both? If opposite sex or both sexes, how many men, women have you had sex with? How many times did you have vaginal or anal sex when neither you nor your partner wore a condom? How many of your partners were HIV positive? If any positive, with these HIV positive partners, how many times did you have vaginal or anal sex without a condom? If your patient is a person who injects drugs, you would ask, have you ever injected drugs that were not prescribed to you by a clinician? If yes, when did you last inject unprescribed drugs? In the past 6 months, have you injected by using needles, syringes, or other drug preparation equipment that had already been used by another person? And in the past 6 months, have you been in a methadone or other medication-based drug treatment program? Based on a patient's sexual history and answers to the risk assessment questions, you will be able to determine if they are at high risk of HIV acquisition and can benefit from PrEP. This table provides a summary on PrEP use. One thing to point out is persons are at higher risk of acquiring HIV via sexual contact, whether they are a male who has sex with men or are a heterosexual male or female, if they have an HIV positive partner, recent bacterial STI, high number of sex partners, history of inconsistent or no condom use, or do commercial sex work. This table also provides an overview of the clinical eligibility requirements for PrEP, which will be discussed in a later slide. SBIRT for PrEP use. SBIRT is an evidence-based approach to identifying and treating patients at risk of substance use disorders. SBIRT can be adapted to PrEP care and can help providers to discuss PrEP and its benefits with high-risk patients. S stands for screening. Assess the patient's risk of HIV acquisition by obtaining a sexual history and by using the appropriate risk assessment tools. BI stands for brief intervention. Discuss PrEP use and its benefits, and the patient's interest in starting PrEP. RT stands for referral to treatment. Refer a patient for HIV and other appropriate testing, and give them a prescription for PrEP. Monitoring. HIV testing and documentation of a negative result are required within 1 week of drug initiation. If a patient's history and risk assessment puts them at low risk of HIV exposure, it is okay to start PrEP before confirmation of a negative HIV test. Baseline renal function, hepatitis serology, and STI screening should also be done prior to initiation of PrEP. Patients need to follow up every 3 months for HIV testing, pregnancy testing for sexually active females, and STI testing. Renal function needs to be checked every 6 months. Creatinine clearance must be at least 60 milliliters per minute for initiation and continuation of PrEP. To promote follow-up, a 90-day supply should be given so patients are prompted to return for a refill. Counseling patients during initiation and follow-up help to engage patients at PrEP care. Here are some tips to better engage patients. Establish a trusting relationship and promote open communication. Support adherence by identifying and addressing barriers to daily dosing and routine follow-up. Reinforce daily dosing for optimal protection, but be non-judgmental when discussing missed doses. Assess for any side effects and discuss ways to address them. Provide culturally sensitive care during every encounter. Ready, Set, PrEP. Ready, Set, PrEP is a national program that provides PrEP at no cost to individuals lacking prescription drug coverage. Provisions are made to provide PrEP to 200,000 individuals per year until 2029. Patients are able to get their prescriptions from participating pharmacies or via mail order. Patients must have a valid PrEP prescription prior to applying for Ready, Set, PrEP. Visit getyourprep.com or call 855-447-8410 to help your patient sign up for services. Stop stigma and discrimination. Stigma related to HIV is a barrier to patients accessing PrEP care. Be intentional with your language and choose words that are supportive of a patient's desire to start PrEP. Encourage them to talk openly with their friends and family about PrEP to avoid misinformation and to normalize discussions about HIV prevention and care. Instead of saying HIV patient, try person with HIV, person living with HIV, or HIV positive person. Instead of saying to catch HIV, say to be diagnosed with HIV or to acquire HIV. Instead of saying to pass on HIV, say to transmit HIV. There is a plethora of resources for you to become a competent PrEP provider, such as the CDC's Clinical Practice Guidelines, HIV Nexus resources for clinicians, HIV.gov, and healthhiv.org. These resources and other helpful materials are collected into the PrEP Provider Toolkit for ease of access and use in your clinical practice. The toolkit can be found on the main page of this module. References. Thank you for completing this training. Please review the HIV PrEP Provider Toolkit to learn more about available resources for you and your patients to initiate and engage in PrEP care. After reviewing the toolkit, please complete the program evaluation to provide feedback on this training. All feedback is greatly appreciated, and I hope you will apply this training and incorporate PrEP into your practice.